you are right to be worried about this, and you are valid because I feel like I always use that term valid, but it's one of those things you always feel dismissed, or people don't really pay as much attention to it, or they're either freak out and say, "Why are you even bringing this up?" And then other people saying, there's a lot of different voices in here. So I just want you to know that, your concerns and your worry, it's a good thing to be worried about. Your cancer grouping, your family history, BRCA, all that, and you had bilateral mastectomy is not caused by cancer, is not caused by estrogen. Estradiol does not cause it at all. It never did. That was not what does that. What happens is, and this is important, I'll lay this out for you, then I'll give you some options. When you have a stretch in your life where estrogen is dominant and progesterone is deficient, that usually happens in your first few years of having your period when you're a teenager, and then happened in your 40s and late 30s. Usually in that time you don't ovulate very well, and that's when you start seeing women with lower progesterone. It creates this imbalance with estrogen dominance. So the low level of progesterone, higher level of estrogen creates this open window. In that open window there, environmental toxins, environmental contributors, things that move in that direction towards triggering cancer, those things are more active and have a higher chance of initiating, that cell reproduction going wrong. So now you're going down that road and generating cancer cells. When that happens in someone who has your genetic history, then estrogen, while it didn't cause it, it will trigger it to grow further. Because the cancer that you're more inclined to have tends to have more estrogen receptor activity. Now, think about estrogen separately by itself for a moment. Estrogen causes growth. It promotes growth. It's what it's supposed to do. So estrogen grows tissue. It does what it's meant to with collagen and glandular tissue, et cetera. And so when you have a cancer cell with an estrogen receptor on there that's really active, it's going to trigger that cancer cell to grow and proliferate even more. So let's step back a minute. It almost sounded like it's confusing what I said a moment ago. I'm going to be really clear on this. Estrogen did not cause the risk for breast cancer in this population, and the type that you have, it does not cause it. It's the lack of progesterone. It's the lack of progesterone. The progesterone not being present allowed this to start occurring. Progesterone causes cell death in breast cancer cells. Progesterone is an anti-cancer agent in your body, among other things. And so when progesterone is low, estrogen's fine. It didn't start this. But you have those chemicals, those environmental toxins, things that will trigger it. Then your estrogen now can cause the problem to grow and become more severe. Now you've had bilateral mastectomy, so good. That's a great way to just kind of like take that away, that strain away. There are women that I see in your population, and we sit down, we have long conversations about the use of estrogen. In cases like yours, I always, defer to you, what you want and what you feel comfortable with, because that's the most important thing we ever do. If you choose to do estradiol, I am going to be very aggressive because you're more than just the sum of your breast tissue. There's the lining of the uterus. I had a woman who I think very highly of, a patient I've only had for a year, who was put on unopposed estrogen for 5 years before she saw me. And now she contacted my office Friday to let us know that she was diagnosed with cancer. I just started treating her, so I didn't really get much traction on her yet. The thing is, you are more than just the sum of your breast tissue when it comes to hormones in your body. There's the lining of the uterus. There's the ovaries. There's so much to you. So when we do estrogen, people in your case, I'm always very cautious. I'm monitoring every other part of your health. We'll if there's issues with history with the lining of the uterus, we may do an ultrasound before and after or during, whichever. We have a discussion with that. There's a lot of things I think about with your cases. If you've ever watched my podcast, you would see that I have a bias against topical estrogen. And that goes back to my history. When I first was in medical school, I trained environmental toxicology. I really was a big advocate for that, and I still am. And I believe in environmental toxicology. I just seem to have fallen into this area more. And but still, that background environmental toxicology. Whenever a compound comes in contact with you and can affect your health, that's something I take seriously. So when someone puts a topical estrogen on and it can be transferred to your dog, to your cat, to your loved ones, important. Now, transvaginal, yes, you're not going to have really much transfer, so we're in a better place. But if you were to be intimate and have intercourse, there's no timeline for how long that estrogen is going to be on your vaginal mucosa. And if you're using it with some regularity, there's a chance that you're going to have some exposure to your partner. When you have that exposure, and I mentioned this in a previous podcast, when you have that exposure, it will diminish the amount that you have present on your body, so you're reducing the benefit that you're receiving, but you're also going to be getting some on his body. And topical estrogen in men on the penis, leads towards adult onset micropenis. It leads towards erectile dysfunction. It's just, and I just ethically, I have a problem with it personally. Now, there are ways around that. One, instead of using topical estradiol, consider using topical estriol. Estriol, there's 3 types of estrogen. There's estriol, estradiol, and estrone. Estriol is the weakest of all the estrogens, and that's the one that's not associated with cancer. That topically has a better result, and your chances of having an issue with your husband, minimal if any. So I would say the first thing to consider is a topical estriol and see if that works better. There was a recent study, and I'll kind of send it to Justin for you to kind of look at, the American Academy of Clinical Gynecologists, I think it was, ACOG. They're the ones that wrote down that topical estriol in your population is okay. They're not against it. With that said, I still prefer women to use estriol because of their significant other. Another therapy that I do a lot in cases like this, and in your population specifically, I do testosterone. And I know it sounds crazy, like, Brennan, that's insane, but this is why oncologists refer to me a lot. Because if you give this woman testosterone at the correct dosing and you watch the estradiol, because testosterone in a woman and a man's body, testosterone will convert into estradiol. We don't want too much estradiol at all. I know that. So if you give you testosterone and watch your estradiol levels, we prevent it from going too high. We can aromatase, we can inhibit it. But again, the right dose of testosterone doesn't do that. And if it does, we see it. Why would I give you testosterone for vaginal health? Because what makes your vaginal tissue healthy, among many things, one of the big ones is going to be that estrogen that nurtures and helps build up that mucosa. It gives that mucous membrane resiliency, and it creates that environment where healthy flora can thrive, bacteria. And without it, you don't have those things. Testosterone also has that impact and that benefit. So if I gave you testosterone, it could mimic estradiol, and you would have the same benefits, but you wouldn't have to do it topical, and you wouldn't have any of the risk factors associated with using estradiol. So I'm more inclined to using testosterone in those cases. The other benefits of testosterone, as I mentioned in the past, lean, healthy muscle mass, bone density. Testosterone helps with bone density a lot. The overall cognitive part, because estradiol, I talk poorly of it sometimes. I know I sound that way, but estradiol, if it's too high, it's going to cause you to feel crazy. Too low, you'll feel crazy. In the middle, beautiful. But if we can't use that, testosterone has a similar benefit. Too high, not great. Too low, not great. Right in the middle. You have every right to be concerned and worried about estradiol. If someone were to prescribe estradiol to you, I would want to make sure that they're doing everything important that goes along with it, which means labs. So you want them to be testing your estradiol. You want them to testing your estrone. You want them to be giving thought to the lining of the uterus, the ovaries. You want them to be thinking about you as a whole, and you want them to be thinking about your husband as well. Think about that. If I were the doctor right here, and I'm going to prescribe you topical estradiol, and I know that you're with your husband, I'd want to run his estradiol too, to make sure I'm not getting. You have a better understanding of what's in front of you. And you don't have a moment later on where you're like, I did that topical estrogen thinking it was a good idea, but now it caused this and this, and you didn't know. So bringing your oncologist on board now is important, so that way they're aware of what you're doing, and there's no miscommunication later. God forbid something were to go wrong, and there's a better understanding. Also, your oncologist sometimes will have great ideas too, because they see you. And I always have hope for a great oncologist. That we don't always get them. There's a hope. I mean, my landlord, the guy that I get my building through, the guy, he actually, his office was my current office now, and he still is a practicing oncologist. He, he's the one I would trust him talking to you about what you're doing with your estrogen, because he sees you as a whole human being, not just, you're just cancer, not your cancer. I'm saying the cancer risks. Put it that way. I'm sorry, I'm being mixing terms up here for you, and I don't want to. I want to be really clear. I know you don't have cancer, but still, it's good to have that person in your corner who's going to see you as a whole human being, and not just say no. And now you're trying to wander around the wilderness of what can you do, because this is not a good way to go through life with this vaginal atrophy like that.